Okay, I believe that we're ready to go this morning. This is Jim Wonderman. It's my pleasure to have folks join us. We've got a very important conversation today about the future of our hospitals. I'm the president and CEO of the Bay Area Council. This is a conversation that's part of our COVID-19 recovery process. We've been having a number of webinars on key issues that we're all facing here in the Bay Area as we try to recover from this incredible, unprecedented pandemic. So thanks all for joining today. We are, historically, what we found in our community, whenever we had an economic problem, healthcare was one of the things that helped get us through it. We have an economy where about 20% of the economy is related to healthcare, and we have a situation where things are really different this time around. And we had an economist on one of these webinars a few weeks ago who was talking about parts of the economy that were doing better and some of that were doing really terribly. And he mentioned healthcare as one that was doing better and was going to help boost up the economy going forward, help us get through this. And one of our top health executives at that time said, "Excuse me, no, not exactly correct. We're suffering a very, very difficult period of time here as a result of this pandemic, actually worse than anything that we've seen." And actually the numbers would certainly indicate that, as we've seen closure of wings of hospitals, folks not being able to access care that they're used to being able to get it, elective surgeries shut down and canceled. Healthcare spending fell by 18% in the first 3 months of this year. And 1.4 million healthcare workers have lost their job in April alone. The COVID-19 crisis has shown us that the best of the American healthcare system and the incredible workforce that makes possible the fight that we're putting up against COVID-19, but there also reveals some shortcomings, conflicting federal, state, local strategies, unsustainable funding mechanisms. Millions of folks who don't have coverage are straining the system like never before. Unprecedented increases in unemployment at the same time threaten our primary source of funding for the mechanism, employer-sponsored healthcare coverage. So today we're going to discuss the heavy financial toll COVID-19 is having on our hospitals and our healthcare systems, what the future holds for these systems, and how can we really get through this, because our hospitals are a really critical part of our communities. They care for our people, and they're a very, very important part of our economy. So today, to join this conversation, we're really pleased to have three extremely busy people. Lloyd Dean is the CEO of Common Spirit Health. David Entwistle is the president and CEO of Stanford Healthcare. And Mark Golly is the Secretary of California Health and Human Services Agency. And this is going to be a intentionally vibrant conversation. I thank you, gentlemen, for taking the time to do it. I'll start. I know Dr. Golly has only a half hour of this hour program, so I'm going to start with you, but hopefully give each of you a few minutes to introduce yourselves and what your thoughts are on the topic. But I'll start with you, Dr. Golly. And I noticed that Governor Newsom announced yesterday that counties are now going to have a different, begin to have a different approach for how they open up. Give a little more latitude, not just if folks want to be more restrained, but if they want to be, be a little more aggressive. So I'm not sure how that fits into the picture. But what's your impression of how we're handling the crisis and how this affect and your concerns about our systems of healthcare, particularly our hospitals?
Sure. Well, Jim, first, thank you for having me, and to David and Lloyd, thanks for letting me participate with you on this panel. I will just say on behalf of the governor and myself, the call came to hospitals and health providers, and the answer was there and immediate. And what hospitals did across the state was nothing short of incredible. I remember calls where we wondered if we could actually initially start with 15 to 20% surge capacity within our facilities. And overnight, it felt like hospitals found a way to get into the 35, 40% surge capacity by doing things that no one, in other states it was required, in California, I don't know how it all happened, but overnight hospitals did what I would say are many of the right things. They pulled together their teams, their leadership teams. They found a way to reduce admissions through, scheduled surgeries and other procedures, and you took a financial situation head on that was probably the only way we would have been prepared for surviving what other parts of our country didn't do as well with, and other parts of the globe certainly didn't do as well with. So I'm no kidding, forever grateful to the industry for really leading in a truly Californian way. And we know that the consequences of that are being felt today. I think many people wondering how to make payroll, frankly. I think certain hospitals have wisely and thoughtfully considered what that future looks like for them, whether it's on the staffing side or the procedure and services mix side of the equation. And we at the state expect that we're going to have some important hurdles and bumps in the road in our conversations on how we not only support hospitals to be sort of return in many ways to the place that they were as bedrocks of our communities, but also to make sure that we're prepared for something like this again. And it's not even, the next thing like COVID. It's literally months away from now as we worry for a second concern around a surge. And I think California is completely prepared with our county leaders to reinstate certain things that we are currently relaxing. And we expect, I think many of you have seen that squeeze, loosen diagram about how to institute the non-pharmaceutical interventions or those stay-at-home order type of approaches. And we in California are completely prepared to look at that in the future. Jim, you mentioned the announcement yesterday, and I probably don't need to remind most of you on this call that California, as big a state as it is, and dependent on regional and local autonomy and authority, part of the reason why in most every other public health challenge and emergency in the history of California, it's really been led at the local level. And started with that local health officer and the local health directors coming together with their hospitals and clinics to address public health concerns, whether it's hepatitis A or measles or some other often infectious disease. In this case of COVID-19, the spread was so concerning, rapid, statewide, very quickly. The state and the governor really led us through an immediate stay-at-home order. And I know that many of you, all of you are there representing the Bay Area. I will also say, and articles in the media have captured this, the Bay Area health directors and health officers really were leaders for the entire state. They led with decisions early and swiftly that really brought a rapid pause for the state of California that was much needed to get ourselves ready and prepared for what we saw in the last many, many weeks. So it's a credit really to the hospitals, the clinics, and the health directors in the Bay Area counties for helping the state sort of find its way to the statewide stay-at-home order. But the relevance of all of this to yesterday's announcement is indeed this concept that our local public health officers, along with their elected supervisors and health directors and community partners, including hospitals, we really see, as we followed the data across the state, that certain parts of the state are significantly impacted by COVID. Los Angeles County is still an important county for us to keep a watch on, not only because of its size, but 55% plus of all of the deaths in California as it relates to COVID-19 have been in LA County. Nearly half of the cases in LA County. We know that certain aspects of LA County's density and some of the neighborhoods certainly have a higher risk to spread of COVID-19, but certainly we aren't prepared as a state to say every county should move forward at their own pace. But then we have some northern counties that haven't had cases and frankly haven't had a death, if ever, but certainly over the past few weeks. So to treat each county in California the same, I think would be failing to recognize the unique nature of how California is set up and the different communities that the governor is there to serve. So this notion of returning some of that planning and control feature of a public health emergency back to the county level was a key feature of where we wanted to go. And we've done it in such a way that requires counties to not just look at their data around how many cases they have, how are they testing, and what are they discovering, as well as their hospital numbers. And you'll know that in the announcement made yesterday, it was really a focus on how well can your hospital system in your county be prepared for a potential increase in surge numbers. Not that we're seeing today. And I think the challenge in answering this question isn't, well, how can you do when you empty out your entire facility waiting for the COVID-19 cases to come, but how do you do it in such a way that you're still doing many of the typical services hospitals provide communities in the elective or scheduled procedures and surgery area? How do you do that when your emergency rooms are being impacted by normal human movement like car accidents and other trauma? How do you still find space for a surge of COVID-19 patients? Because just as we begin to move and mix a little bit more as a population, and we increase our need for the pent-up service demand of the past few weeks, we need to make sure that the hospitals are prepared on the COVID side. So we've asked the counties to work with the hospitals to come up with a thoughtful plan, attest to the state that they have it, and then be able to move forward. So I think the good news is we have a hospital system that is prepared and sort of battle tested, if you will, with COVID-19. But I also think it's going to amplify some of the pressure to be able to both do that normal piece of business while also preparing for a COVID-19 surge, which of course is going to be a challenge like we've never had. So with that, I'll stop and turn it over to you, Jim, and happy to stay on and try to answer some questions.
Sure. Thanks very much, Dr. Ghali. And, we certainly revere our county health officers and Governor Newsom and mayors in the Bay Area who took the aggressive action, which really kind of helped us not see the surge that we were expecting to see. My wife and I were in the hospital 6.5 weeks ago having a baby daughter, and it was just an amazing scene, and seeing what the hospital did to prepare for the surge that actually didn't come because folks took those actions ahead of the rest of the country. And we're the beneficiaries of that. So I don't know how many thousands of lives were saved here in the Bay Area, but we owe it to our government leaders for stepping in at just the right time as they saw the numbers start to go, and took an action that probably wasn't universally popular, or we hadn't seen anything like this before. But turns out they did exactly the right thing. And I know the members of the Bay Area Council are very appreciative of that. I think it also gave time for the hospitals to be able to get the equipment that they didn't have, the gowns, the masks, the ventilators, and other things that were really needed in order to, if there is a second wave, at least next time, we're sort of in a better position, wouldn't you say, to address it, even if it's big?
Yeah, I mean, there's no doubt that what we learned was preparation is key. And I think a number of the leaders on the call, and Lloyd and I have had a couple conversations about testing and building up our surge capacity and even alternate facilities. And I'm grateful for Lloyd and his team and all they did. And certainly David's team and at Stanford has been part of our testing task force, really ramping up. So on some of the key measures, including how prepared are we for surge beds, but how are we doing with testing, and how can we sort of sniff out through early indicators in testing and contact tracing potential hotspots or surge areas throughout the state? How are we doing also on PPE? Whoever knew we would have governors across the country talking so, not casually, but in such a degree of sophistication about N95 and surgical masks and PAPR and face coverings, and all of that is now part of the normal lexicon. And I'm sitting today at the State Operations Center, where frankly I've spent most of my last 3 months of life planning and looking at the number of masks we have coming in that we're distributing to hospitals and other care facilities. And that is not just masks, it's gowns, it's everything else. So really trying to prepare. I will say, and Jim, you led with it, one of the most concerning areas is making sure that we have the staff needed, because there are both worries among the staff that we can't protect them at every corner or every turn, and we need to be able to, so that we can have those superheroes, as many of us call them, go into the hospitals and the care settings with some confidence. I think that's something that the state and Governor Newsom has taken very seriously, and we have both spent quite a bit of time and resources making that happen.
Well, thank you very much. Let me ask for some opening comments from Lloyd Dean and David Entwistle, and maybe if you can stay long enough, we can come back to you, Dr. Ghali. But these are folks who are running, top institutions of medical care in our state, and have just been at the affect and of this virus. And things must have changed a lot from what you guys were thinking about a year ago. So tell us, I'll start with you, Lloyd. Tell us what you're experiencing and how you're seeing it trend at this point, and just how deep a problem is it for our hospitals?
Thank you, Jim. First of all, I just want to say thank you, and thanks to the Bay Area Council for hosting a conversation like this that I think is critical, not only to California, but to the nation. And also, I just want to acknowledge Mark's leadership and David's leadership throughout this whole journey that we've all been on together. And certainly, I think our governor has stood tall among governors throughout this nation. Suffice to say, many aspects of health and healthcare in this state, in this country, have changed, and I would submit forever. We are at a point of what we do today will determine our tomorrow. And when you talk about change and talk about health and talk about healthcare, our world has gone through a dramatic change in a very, very short period of time. When you think about what we do, where we deliver care, how we deliver care, who delivers care, now patient and consumer expectations around that care, and cost-related issues, yes, our world has changed. To be specific, our journey, like other health and healthcare providers, has been a dramatic one. We spent the first part of this working diligently, 24 hours a day, trying to secure PPE and equipment to ensure that our caregivers on the front line would be safe. Certainly, we were confronted with the challenge of ensuring that we retain our staff and that we have the necessary staff in the right place at the right time to deal with what we were facing. Then we went into a phase of preparing for the surge, and that cost each of the healthcare institutions around this state and around the country dramatically. And I thought maybe I'd jump right in, giving you some statistics about our ministry or our organization. Our losses have exceeded $1.5 billion and continues to grow. Yes, we received some help from the Federal CARES Act of $713 million and another $10 million from the state. We continue to plead and to advocate and to compel upon FEMA to distribute the remaining funds that it has to those institutions and to those of us involved in the healthcare sector to ensure the infrastructure that is not only needed today and that we have experienced what it's like when that infrastructure begins to get rocky, but to ensure that, and as Mark said, to help us get prepared for what we know is inevitable, we're going to be faced with in late August, early September and October, and that's going to be the convergence of COVID-19 with the influenza season. We also did receive a $2.6 billion Medicare advance. As folks know and hopefully understand, that is repayable. We have now 10 months to pay that back. That was not a grant or a gift to us. That was an advancement of Medicare payments. If hospitals had not received that, we know categorically that some hospitals would not have been able to move through this crisis and to continue to deliver care. I could go on and on about all of the things that we did in terms of working with partners in the community, working with UCSF to identify and to set up a unit for the surge. We worked with the state and the county here in Los Angeles, along with Kaiser, to reopen St. Vincent and to prepare for a surge there. But all of this has come with a cost. So I think that it is incumbent upon this nation. We need more support from the federal government. There's no question that our testing throughout the nation has not met the expectations that any of us had hoped for. Yes, we are making progress, but we need to move quicker. We need to be able to do early identification of hot spots within counties and within geographies. We continue to search for and to ensure that we have enough personal protection equipment for those on the front line. No matter what you read or what you hear, that continues to be a challenge for all of us. But think about this. Think about what we had to do. Almost within hours, we had to halt our elective surgery and other services. Like a switch, we had to turn those off. And that caused all of us to have incredible drops in our volumes. On average, our system, we lost more than 40% of all of our volume almost instantaneously. That caused us to have to reduce our discretionary spending, to halt travel, to stop capital projects. We had to stop non-essential hiring, looking at all of our contracts, all of our supply costs. Our executives, starting with myself and many others across the state, took pay reductions. Our facilities had to begin to manage in a very didactic way our staffing hours. But I am proud to say that in California, working with people like David and Mark and all of the other healthcare and health entities working with the California Healthcare Association, we were able to meet the challenge. But the challenge goes on. And Jim, you'll hear from David in a moment. We are deeply concerned because even though we are seeing things leveling off, we are seeing supplies coming in, it is not sufficient. And until we get a vaccine, I believe, and I believe this from the bottom of my heart, that the healthcare infrastructure of a state, of a community, and of the country is going to have to be in a position to perform. And we cannot do that without the support of our states, our counties, and yes, the federal government. So I'll stop there so that we can hear from David and be happy to engage in the questions with Mark and David.
Thanks so much, Lloyd. And you said so many profound things there. And, we want to, help get the word out, because I'm not sure everyone understands this, certainly not the way you understand it. And, we've got so many hospitals, and I think we kind of take you guys for granted that you're there and you'll always be there. And, we know we've seen some hospitals close in our region from time to time, and we don't want to see that happen as a result of this. And maybe later we can talk about the risk of that happening, especially in some of our more underserved communities. Let me turn it over to David. Dr. Ghali mentioned the testing regime that Stanford is involved in. Maybe you can talk about it somewhat in that context as well. But what are you experiencing in Stanford, and and Lloyd mentioned the vaccine situation, and we had a little bit of news on that yesterday. Somebody says something good about a vaccine and the stock market goes up 1,000 points. Maybe they'll say something bad and it'll drop. But what do you think about our current situation when it comes to testing? Are we getting better at this, really?
Well, let me avoid any negative comments that'll drive the market down. I certainly hope that influences out of this. But let me just say, Jim, thank you. First off, I will do as Lloyd and Mark did. Thank you for your leadership. Thanks for bringing us together. We appreciate the Bay Area Council, and I'm honored to be on today. Also honored to be on with Lloyd, who's been a great colleague and friend as we look at the work that we do in healthcare across this setting. And he's been such a leader to really demonstrate what needs to be done as well. And Mark, thank you. We appreciate, and the governor's really forward thinking as we think about the fact that we did be proactive. Actually, we did the sequester. We've seen from the data that has made a difference in what has happened in this state versus what's happened outside the state. So just tremendous work here, and I think the proactiveness there. Let me just touch on a couple things, and I don't want to duplicate what Lloyd said. Our numbers, as we look at this, we have about $250 million that we have lost in revenue just over the past couple months. I mean, that is significant. We will get, it's been announced, we'll get a little bit over $100 million in financial support through the CARES Act. We hope, as Lloyd said, that FEMA will produce other revenue sources as part of that. But as with most disasters, that can be a long time coming. Healthcare organizations are struggling financially. There will be some that don't make it out of this. There will be some that cannot withstand the financial challenges. As Lloyd talked about, we did get a prepayment on Medicare. For those, they basically took the average of the dollars of what we were getting and made a prepayment in cash. However, that will be debited out. If we don't use that, we have to pay that back. But it's just basically a prepayment. That doesn't help for at least us in that $250 million loss in revenue. That's what is challenging. And I think as we think about those services, we have been investing, we are staying open. As Mark talked about, we immediately shut down. I took my capacity, which is in our main facility here in Palo Alto, from 600 to 265 in about a week. We shut down, we delayed surgeries, we delayed cases coming in. We saw about a 40% drop in our inpatient capacity, about a 50% drop in our elective surgeries. well, I should say 50% drop in surgeries because we took all the elective surgeries out. That is dramatic. And then the hope was then that we would have the capacity. We spent tremendous amount of additional funds bringing units back up, creating that surge that Mark talked about that we needed. So we are ready for what would occur. Now, fortunately, that didn't occur. We saw great perspectives here in the Bay Area. We did not see the dramatic experiences. Having just talked to one of my colleagues who's my peer at Johns Hopkins, who had just 2 Fridays ago, 333 COVID patients in his main hospital in Baltimore. Over 100 of those in the ICU, 80 of those on vents. We didn't see that, fortunately, here in the Bay Area, and I'm so glad. That's one of the perspectives. However, as Mark said, LA is in a different situation than we are here in the Bay Area, so that's challenging. So what does that mean? Certainly financially, this is going to be challenging to overcome. We're having a lot of expenses. Who would have ever thought that PPE would be part of our nomenclature of acronyms that we knew? But it's something that's critically important, but it's also helped us in terms of keeping our healthcare workers safe. And as Jim said, let me just talk for a minute about testing. One of the things that was very fortunate, we have a great team here at Stanford. We were literally the week after this really, so to speak, hit the fan here in the Bay Area, we were able to have one of our faculty that got an FDA approved test for COVID that allowed us to do that testing here internally and for many Bay Area hospitals. That was prevented some of the delays that were occurring in some of the other sites and gave us really a window into that. Testing is an important aspect. However, it gives you a single point in time of when or if that individual has COVID. We actually also further about 2 weeks later got approved for a serology test, which actually allows you to test for antigens, whether you have the ability to have had the virus and be able to develop an immune response to it. It's very challenging because, you know, with a flu, you can have an immune response in about a week. Unfortunately, with COVID, it's about 3 weeks. That's why it's been so challenging. As you look at what Lloyd and I, for those patients who we have in the hospitals, it just extends that length of stay, and that's one of the challenges and why the state asked us to build that capacity. Now, part of what we have going forward in that expense is going to be that we have to keep that capacity available. We don't know what will this virus do. We know that it slowed down significantly now. We know that it seems to be on a very downward regression trend here in the Bay Area, but we don't know how that will respond. And so we've got to keep that expense in place to make sure that we are ready. Now, at the same time, we've also got to care for those patients who aren't getting care now. And I will tell you, having had the opportunity to speak with my chairman of cardiothoracic surgery yesterday, who was operating on 2 patients who had both delayed care, and as a result of that had significant challenges that won't be repairable when you look at their cardiac health that he's now trying to respond to. And so I really say that as we think about in the Bay Area, especially as we think about healthcare providers, we want to make sure patients know that it's safe to come back. We were proactive in actually using that testing capacity that we've had. And I share with you this number so you know of an incident with one hospital here in Palo Alto. We tested all roughly 14,000 of our employees with both the COVID nasal swab test and with the serology test. We wanted to know from our population, again, that would be one point in time, of the population that we tested, 0.3% showed COVID. So that means 99.7% of all of our employees had no COVID disease. Now, an interesting part on the antigen test, what we did notice is that 1.8% of our employees actually had developed the antigen. That means they had had the virus and never known, because anybody that actually had symptoms we were testing already. So we do know the prevalence of the disease is down. It was more important for us because as we're trying to encourage patients to come back and get their care that they're delaying, that's important for them to know they're coming into a safe environment. And so we've actually started back with our elective surgeries that have started 2 weeks ago. We, in a typical basis, would see about 12 to 1,400 surgical cases in a week. Our first week back, we did about 900. This last week, or in the second week, we had about 1,200. And so it's nice to see that people are getting the care that they need. We know that that's the delay is causing harm. Cancer doesn't stop growing. The diseases don't go away. And so I do think that we're going to have some challenges as we think about some of the things that are actually coming back and the things that people will need. We know that people are also nervous, and I think that's where the testing comes into play, and I think that will be helpful as we actually give that point in time care, but there's a lot that we have to go on now. Let me just, Jim and I'm probably running out of time here, but let me just share that one of the things that I hope will be a highlight that comes out of this is what we're now doing with digital technology. We can now do a lot of the care that had to create a visit to the hospital, visit to the clinic, can now be done digitally. Now that technology was there before. We sit here in the Bay Area. There's a tremendous amount of Bay Area companies that have developed some great technology. It's just we were not using it, and the government wasn't paying for it at the same time. And so that has really opened up. We have gone on our outpatient visits from 2% digital to over 70% of those being digital. Think about what that will do going forward and the ability that we have to be able to provide care digitally, help keep people safe, save PPE, all the things that go into that. But we want to make sure that that's something that we help hardwires into that. So we know that it's going to continue to be challenging. As Lloyd said, I want to reiterate, financial is going to be challenging. We know that there's going to be challenges with the payer system. There's going to be fewer jobs, fewer people with commercial insurance, which means more individuals on Medi-Cal. Medi-Cal does not pay the cost of the care that we provide. I want to be very clear on that. Even though Medi-Cal is a great piece and it provides resources for those who don't have insurance, we lose money on every patient that comes in on Medi-Cal. And so it's going to be challenging with fewer jobs, fewer patients, if we have businesses that actually, unfortunately, are not able to provide that insurance. That's going to cause further hardship on Lloyd and I as we think about the revenue sources going forward. So just a few things that I know academic health centers are around the country responding in many different ways. And it's great to be on the call and share just a few thoughts with you. Jim?
Well, thanks very much, David. And, it's really amazing, what you're going through and what you're doing, and, the mention of digital care. Maybe there's some silver linings that come out of this process. There should be, as we put us on track future, where maybe we some types of healthcare more efficiently. I know some folks, once in a while, you need to get to actually be in the same physical space as you're a physician. I was wondering when Dr. Ghali's comments about the second wave, and we're all thinking about that. And so you've both endured this incredible financial hit as a result of the first wave, and some are predicting the second wave can be bigger. So what can be done as you prepare for this to make sure that, not only do the patients who come along get the care that they need, which I trust they will, but also that we don't just keep subjecting ourselves to a financial situation that's clearly unsustainable. I'll start with you, Lloyd.
Yeah, I would say, first of all, that's a complex question. And I'll, touch upon some of the aspects of what I think is the answer to it. Number one is that, shame on us if we haven't learned a lesson about PPE, about what we need, where do we need to have it distributed to, and how do we acquire it. What we found ourselves on this planet with was a situation of countries competing with countries, then countries competing with states, states competing with states, communities competing with communities. We know now that we are going to see some of the trailing effects of COVID-19. There's no question about that. So we know that there's going to need to be a certain level of PPE available to our access points and to our institutes. So I think hopefully that will be better. Secondly, we need to know that, and we're learning a very difficult lesson about the importance of testing and antibodies and those kinds of things. So we should be prepared for that. We know that we are going to have to be ready for surge capacity. And as David so eloquently said, we're going to have to be flexible and agile to begin to quickly staff up for that. So we've learned some lessons, but what I am fearful of is that by the time, no matter the most aggressive projections and predictions, that, and I pray every night that we will have a vaccine, but as David said, I think by the time period that we're discussing here, I don't think even if we have one, that it would be widely distributed. So we are going to have to deal with almost an unprecedented conversions, as I mentioned earlier, of influenza and COVID-19. That is going to be a staffing issue that's going to be where we deliver care. But again, some lessons learned. Everybody does not need to immediately go to an ER or to an ED. So how we use televisits, how we do assessments through other means is going to be critical. Where and when do we set up specific kinds of services and activities? How we utilize our staff. One of the things that we haven't mentioned on this call is the toll that this has taken on caregivers throughout the spectrum, physicians, nurses, but caregivers, frontline individuals. And how do we support them? How do we engage with them? So again, shame on us if we haven't learned some lessons. And then the last thing is consumer behaviors. We are going to have mechanisms in place to control the flow of patients, when, where, and how do we use other aspects beyond the infrastructure of the hospitals. I'll stop there and yield to
one quick thought. Thank you for that, and that I think that was a very comprehensive answer to what was a complex issue that we're likely to face. David mentioned the return to elective surgeries. Are you having the same experience at this point? Are you pretty much back up to where you were, at least for now?
Well, I'm always jealous of David because he moves fast and quicker. No, we are certainly are returning. We went to, I use the analogy, we flipped it off with a switch. We're seeing kind of a dimmer effect in terms of it coming back. Where David is at 70, we've probably now reached 50. But the good news is that it's coming back. The challenge for us and what we're watching really closely is how much of that has been, as David referenced, kind of pent up need that folks had because their confidence and their ability to access care was compromised. How much of that, will there be a leveling off? But as I talk to my colleagues around the country, many of them are seeing continued growth. So that's a good thing for us. And again, I think the last time that I looked, we were at 46 or 47%. But it seems to be moving quickly. One other thing while I have the floor I promise I'll respect David's time. One of the other things that we've learned, and again, shame on us, is that there are certain populations that need certain kinds of attention in some priority. When we think about the disparities that we saw relative to people of color, relative to African Americans in terms of mortality rates from the virus, when we know about social determinants of health, and we're going to have some policy changes and some resource management to ensure that some of these hotspots, which could have been better controlled through resources and through a bunch of other very effective things that we know work, we're going to have to put those in place. And David.
Thank you. Thanks, Lloyd. And you folks are in an amazing business because unlike other businesses, when people show up at your door demanding service, it doesn't matter whether they come with money in their pocket. And you have a relationship with the government where you're required to provide this care, and the government only has certain requirements. And I think this situation and how much you've received through the CARES Act and the gap as to what's required in order to make you whole, it's not just significant, it's it's more than material. And so, and the future, depends on you being able to balance your budgets and be able to hopefully, provide the kind of care you need for all your patients. And so, David, you mentioned the payer system. And Lloyd, when you were chair of the Bay Area Council, you and I talked about this a lot of times, that, this is an industry, hospitals, with a very unbalanced, probably maybe unfortunate business model in which, some folks can pay, some folks can't pay, some things are expensive, some things have to be cheap, some things just have to be done, and you have to balance of all those needs. Is this the time, given the exposure, this is a pandemic, we can't run away from it. Is this something we should really be looking at this point, is to maybe reform, the system of payment for services so that, in the future, we can start heading towards more of a normalization? I know that's a more complex question than the one I asked Lloyd. So I'll ask you, David.
Yeah, I don't know that I probably want to touch that one. That's a challenging one. I might give that one back to Lloyd because he so eloquently answered the last one. Well, let me just tell you, as you know, and I am sure, not having participated in those Bay Area Council discussions, there is a hidden tax that's built into Medicare and Medicaid that gets made up by commercial health insurance. Unfortunately, there is an ill balance that occurs in my very thought of saying this is going to be challenging to hospitals going forward, because as the more we transition to Medicare, Medicaid in the state, it's going to create more financial challenges. Now, is that fair? Certainly not. Is that reasonable for businesses to make up that proportion for healthcare? No. The reality is that's where we're at. How do we start that conversation? I think is going to be very difficult. Going back, right now under even some of the current political debate, even talking about more Medicare for all, or even lowering the age of Medicare for individuals, which has been part of the debate, that too will be challenging as you think about that, because who funds that? That's the challenging aspect, and that, quite frankly, I think is going to be hard discussion going forward. I think this is always a debate that should be in front of us, and I hope at some point we do have perspectives to bring more reasonable to that payer model, so there isn't that inequities. I will say, though, for the time being, we have been more focused, and I think our government officials and elected officials have stepped up, having what we've seen in the CARES Act and even some of the other money. But as Lloyd says, there's going to have to be more for that to balance out some of the things that we're going to see as this challenge goes forward with the inequities that will occur because of the loss of insurance. I think it's going to be even more challenging. But I think that's a debate we've got to keep in front of us. But whether we use this as a sounding board for that, I'm not sure, Jim, yet where we're to that point.
Yeah, let me follow up. And by the way, we have about 10 or 11 minutes left. If you have a question in the audience, please put it in, and I'll try my best to get to it. The question on elective surgeries actually came from the audience, and we had another one, David, on testing. That there's wide variances in what's suggested in terms of how many tests we need to be doing in the community in order to get at this. Do you have a sense that, is there a right number that's out there? Are we hitting those kind of numbers now, or are we still, far off from where we need to be? To both you, and then I'll ask Lloyd and another.
Well, let me comment on this, because one of the things, and I literally say that when you have a COVID nasal swab test, and we've had all of our employees, I've done that. If you haven't seen that, there's literally something they insert about that long. It's a little uncomfortable, some say painful, but that tells you at that single point in time, do you have COVID? And that's important. The reality is many folks that may have COVID may have not had the symptoms to it. May have not have been able to recover from it. That's what we saw from the 1.8% that we tested that had the antigens. Now, where does the testing leave you? I think for us, it left us with a feeling of confidence that I knew that I had a workforce that was ready to give care back to patient. And we have not seen in our organization any transmission of a provider to caregiver or provider to patient, or the reverse, the uptake of a COVID case because of that. So PPE works, we know that. And I think as long as we keep that safe. Now the question is, does it bring a greater feeling of safety for individuals? So we have talked to many companies across the Bay Area about doing, like we did, asymptomatic testing so that they feel as though the workforce knows. I will say it brings a great level of confidence to our employees to know that COVID is not present in the work environment, so that when they come to work, they aren't taking it home to their families. I love what Lloyd said about the impact on healthcare professionals. It's traumatic to come home and your family thinking that you could be a carrier to COVID for them. So seeing the testing that certainly has been encouraged to ramp up, I think it will bring a greater awareness of how much COVID is actually in the community, how much that we've actually seen. Of the 58,000 tests that we've done, we've only seen a 4% repositive rate, and that's across everyone, both symptomatic and asymptomatic. So I do think testing will help, and the state has done a great job in help standing up and doing more testing, but I think more needs to be done there.
Yeah, I had that. I had the test, and it is uncomfortable, but it was a relief at the time when it came back negative. Since we were having a baby, to know myself and my wife didn't have it. It wasn't easy to get the test at that time. I take it now; it's a little bit easier. Lloyd, what's your thinking on this?
Yeah, I'd make the following observations, and certainly echo and support and say kudos to everything that David said. I would just add that I think there's a lot that we can do, and within your question are sub questions, and I would start with the first. Number one is that we have to have a standardized test that we all believe in. That this nation says for this situation, this is the test. If you'll, do a retrospective look at kind of where we are today and all of the different amalgamations of different aspects of testing. This test did work, this test didn't work. I'm not sure that this test, if you take it today, if you take it a week from now, you might get another different results, also false positives, those kinds of things. So first of all, we need to determine and have tests by greater minds, certainly than mine, but there are people who can identify this is the right test for this situation. Secondly, we need to have the debate, and again, I think this should be led by the experts and not a political question. Who needs to be tested? The question is, does every citizen in the United States need to be tested, or is there a hierarchy of testing? Are there communities? Are there certain signs that in geographic or medical ones that we would see? And then the third thing is distribution of testing. Let's be clear where the responsibility lies. Is that a federal accountability? Is that a state accountability? Is that a county accountability? Is that a care? Is that a physician accountability? Or is that a clinic? Or is it all of the above? The greatest nation on this planet should have an architecture of how testing, best practice, should be done under circumstances like we're experiencing. And then again, what does become the political issue is it in the best interest of a community or of a state or of a nation to provide that testing, whether one has the ability to pay or not? Does that ultimately lead to the safety, the security of the nation or of the world?
Thank you. A couple of quick questions. I'll look for quick answers. There's a question around the collaboration between the primary care providers and the hospitals, how that is going. What can we do to ensure that those relationships are being maximized so that we're getting the best ultimate care for our patients? Maybe I'll just kind of throw that one out there. How is it going with the primary care providers at this point, sort of in the middle of this, hearing from people that they may have this symptom or that symptom? How's that working?
Let me just say, we've tried to work very closely with our primary care networks, and I think they're an important aspect. They are literally the front line for folks that are coming in and getting tested and making sure that we're available for them, providing e-consult, many different things that allow us to be able to do that and make sure, importantly though, they have the resources they need. I worry about them though, because they're struggling financially as well. If you look at what their ability to create a revenue stream there, And so partnering with them in many cases, as we've done in our community, and I know Lloyd has as well, that'll be an important aspect, is how do we work together to get through this?
And I would just add, Jim, that I am very, very pleased with the cooperation, the partnership that I have observed, not just within our system, but throughout the state and the nation. So I think that they are working very, very hard. And I think that with that partnership and that interplay, I'm very proud of. Have they faced some of the same challenges that David and I have mentioned about being caught off guard a little bit with the PPE and the testing and those kinds of things, and some of the other issues that we've mentioned? Yes. The only thing, I wish there were more of them. But other than that, and making sure that they have support, as David said, so that when they are going through these difficult times, that they will come out even stronger on the other side of this. And that's something that I think, as a nation, as a system, and certainly state, and we can do our part to help secure their future.
We only have a couple of minutes left, so I'll ask a quick question, from myself and organizations like the Bay Area Council. What can we do to help our hospitals through this? Where can we most effectively advocate?
Let me just share, I just appreciate groups like this and sessions like this that bring awareness to what the challenges are. We appreciate all the support. So many people, I want to thank, have stepped up, whether that's donating PPE, whether that's coming in to volunteer to help in certain circumstances, whether that's donating food. I just want to say thank you for the tremendous outpouring of love and support, whether that's the blue ribbons that are tied to the trees that we get to see, whether that's the first responders showing up at our front doors to thank our staff. I just want to say a great appreciation, Jim, for pulling this together and also creating the awareness. Thank you.
Thank you.
Yeah, and in addition, Jim, my short answer would be to use your voice and your the platform that you have to advocate on behalf of the importance of the health and healthcare infrastructure for our community, and for a state and for the nation, and having adequate funding, particularly during crisis like this, to ensure that we come out stronger, and that we learn lessons here and apply it. And again, I just want to end by thanking you, thanking David and Mark for this discussion, and just from the bottom of my heart, saying to all of the caregivers out there, whatever your category, thank you, and thanks for all of the partners who we're on this journey with.
Thank you. Well, I think that's a great way to end it. Lloyd, David, Dr. Ghali, I think it was a very informative session. It's a conversation that will continue, and we want to work together as your partners as we work through this and come out. There's so much pent up goodwill now, I think, toward the institution. Let's take advantage of the moment. So thank you very much for participating, and maybe we'll get it around to round 2 of this a little bit ways down the road. Thank you, everyone. Have a great day. Thanks for checking in with us.
Yep, and thank you so much.
Thank you.